Thank you. Hello, everyone. Let me just share the presentation, which is, how do I share this?
No, click on this one.
This is just showing the screen, fine.
Yes.
Okay. Lovely. So hopefully everyone can see the slides. I assume they can. Hi, I'm Jem. I'm one of the F2s at Northwick Park. I'm sure I've met some of you. I hope you're all well. Confessions is I completely forgot I had to do this. This is rather hastily thrown together, but hopefully it will still have some interest to some people. And I tried to focus a little bit on things that I would find useful at my level of training. So there's a little bit more on acute liver failure rather than chronic, because I don't see it very much, and I don't know if other people do, but I assume we sort of don't. So I'll keep it relatively brief. I assume it's probably about 15-20 minutes, and if anyone has any questions, hopefully I'll be able to answer them. So today we'll be talking a little bit about acute liver failure and a little bit about chronic liver failure, though in chronic liver failure, focusing more on spontaneous bacterial peritonitis and hepatorenal syndrome rather than chronic liver failure, because I think everyone gets quite a lot of teaching on chronic liver failure. So we'll start with just a little bit about the common features for both of them, which is literally a slide, very quick, and then we'll talk about acute liver failure, its diagnosis, etiology, investigation, particularly of encephalopathy, the coagulopathy, and then treatment specifically for sort of like an ITU A to I approach about what we're looking for and what sort of treatment we'll be offering, and then we'll talk about chronic liver failure. I will probably also be eating a jam donut partway through. I apologise. So, liver failure, acute and chronic. Things that you'll see in both will be jaundice, unsurprisingly, coagulopathy, so the synthetic function of the liver, and encephalopathy. And encephalopathy particularly important in acute liver failure, which I'll talk about. You'll notice that I haven't put ascites here. Ascites is more really a chronic issue, a cirrhotic picture where you have this sort of dysfunction with the portal system of hypertension and accumulation of fluid in the peritoneal space, which doesn't happen really so much with acute liver failure. So, thinking about encephalopathy, which we're starting with acute liver failure, so encephalopathy is particularly important for acute liver failure. So the pathophysiology of this is that you have an inflammatory response, which we'll talk a little bit more about when I'm on the acute liver failure page. A combination of inflammation, so microvascular and macrovascular changes, circulating toxins, the most important of which for our purposes in this talk is ammonia. Normally the liver will metabolize ammonia to urea, which will then be excreted by the kidneys. You pee it out. Obviously the function of the liver is impaired, so ammonia will accumulate in the bloodstream and will therefore accumulate within the brain. And osmolar derangement, particularly of sodium, is not just sodium, but hyponatremia, particularly important. And what the combination of these three things, the effect that has, is that the vascular function and regulation of the cerebral vascular system is disordered. And this leads to astrocyte damage, swelling, subsequent edema, and intracerebral hypertension. And obviously, if uncorrected, then this can lead to irreversible damage. But in most cases, it won't reach that stage. And hopefully, we should be taking steps to prevent that. In terms of grading, I'm sure people have seen the grading, but 1, 3, 4. 1 being sometimes quite difficult to necessarily pick up. Someone's maybe just a bit more irritable, perhaps it appears a little bit confused. 2 is more obvious, and I think where we see most of our patients in the general medical ward, they'll be between 1 and 2. That's when we start seeing things like maybe the hepatic flap. They become pretty disorientated, drowsy. They are obviously not themselves. At the point that you're getting to grade 3, then that's perhaps more like the sort of patients we'll be seeing on intensive care, where there's real gross change, confusion. They might be sleepy nearly all of the time, and they're not that far off going into 4, which is obviously a big problem. Coagulopathy, I won't blast on too much about this, but this is because the synthetic function of the liver is impaired. Lots of clotting factors, coagulation factors, factors that are both prothrombotic and anticoagulant are produced by the liver. Therefore, if you had some kind of acute insult, or if it's a chronic insult, then that production is going to be impaired, and therefore you will see the outcome of that in your coagulation screen. So typically for acute liver failure, we're looking at an INR more than 1.5. For those of interest, if you were to look at all of the clotting factors in the blood in someone with an acute liver failure, you'll actually have a predominance of factor VIII and von Willebrand factor. They seem to be less affected by the loss of synthetic function. However, in terms of correcting, we shouldn't be routinely correcting this sort of coagulopathy because it's both prothrombotic and anticoagulant. So there's not necessarily a good rationale for trying to correct things. You would also mask the change in INR, which might be useful to monitor the progress of that injury and prognosticate. So in general, you shouldn't be correcting. You see someone, I don't know, you shouldn't be chucking fresh frozen plasma at someone unless there is a reason for it in acute liver failure. So maybe if they've got acute ongoing bleeding, or there needs to be some kind of invasive procedure, then you might, and you're better off using sort of point of care testing, which I'll come to a little bit later, the thromboelastography, to guide exactly what products you should be giving. Liver failure. Okay, so I focused a bit more on acute liver failure on this presentation because, to be honest, I didn't know too much about it, and I haven't really seen it very often. I've seen quite a lot of chronic liver failure, and I think probably other people's experiences are similar. So, diagnosis, particularly important, is the encephalopathy, and it's the onset of the encephalopathy to their jaundice. You will see a coagulopathy as well because it's a liver failure, but particularly important is the encephalopathy. And key for an acute liver failure is it's someone who had previously had a healthy liver. They don't have cirrhosis, they haven't been abusing alcohol, they don't have a history of hepatitis C or something. It's new. The exceptions are if they're index presentations of some of the more rarer things like Wilson's or autoimmune hepatitis, but it has to be the very first presentation in which they're presenting with an acute liver failure. Otherwise, it's people with no previous liver issue. If they don't have the encephalopathy, it is not an acute liver failure. That's an acute liver injury. So if you just have the coagulopathy, this isn't acute liver failure. The encephalopathy is key. The sort of categorization of that, whether it's hyperacute, acute, or subacute, is purely based on the onset of sort of a diagnosable onset of the encephalopathy compared to the jaundice. So hyperacute is within 7 days, acute 7 days to a month, and then subacute is beyond a month up to 12 weeks. Particularly key is that encephalopathy. So, I've nicked this slide pretty much wholesale from one of the sources because I thought it was really good. So someone's appeared, they're in acute liver failure or they're in liver failure. What investigations are you doing and why? So I'm splitting this into looking for an etiology and then looking for or monitoring the function of the liver. So in terms of etiology, you're doing a viral screen, you're doing an autoimmune screen, you're doing a drug screen, and then you're doing your slightly more specific old ones like Wilson's disease. I've never seen Wilson's disease. I don't know if anyone else has ever seen it before, but I think this is a really good structured table for making sure you hit all of the different possible etiologies and why you're doing it. Interestingly, 20% of acute liver failures have no cause or no known cause, and they're called cryptogenic. In terms of the pathophysiology of the acute liver failure, so you have some kind of direct hepatocyte damage. So let's say it's a paracetamol overdose, which is by or poisoning, which is overwhelmingly the most common cause in the West. It's not the most common cause globally. Globally, I think it's hepatitis B and E are the most common cause globally, but in the West and in the UK, it's paracetamol poisoning. So you have some kind of hepatocyte damage, apoptosis. As a result of the lysing of these cells, you have DAMPs which are released, which are detected by immune cells, natural killer cells, macrophages, monocytes, dendritic cells. And these induce a large inflammatory response, a bit like you would have with sepsis. Because you have this dysregulated, large inflammatory immune response, you have multi-organ dysfunction, which is similar to SEERS in sepsis. Over time, you'll end up having an anti-inflammatory response, and because the liver is now impaired, you have an immune paresis and you're vulnerable to secondary infections. But the initial stage of this is very, very similar to sepsis, and that's why you'll see when we come to the treatment part, you treat it in a similar way to someone who is presenting with sepsis in terms of your fluids and antibiotics and things like that, but we will come to that. But predominantly, the effects that we're seeing are because of this inflammatory immune response. The coagulopathy and the encephalopathy are because of impaired synthetic function of the liver. So looking for the investigations of the...
Sorry, I've just got a few chairs that I'm holding.
Okay, yes, sure, whatever, that's fine. Following the function of the liver. So we have our LFTs, where obviously we're following the hepatocellular or cholestatic picture and seeing how that progresses with time. We've talked about coagulation. I'm not going to talk much more about that. In terms of our ABGs that we'll be doing regularly every sort of 2 hours or so, particularly when they first come to the ITU, we want to be following that lactate and making sure it doesn't rise too far. Lactate is metabolized by the liver, so again, it's synthetic function being damaged causes accumulation. Ammonia, we've talked a little bit about ammonia already, but this is the most important toxin that can cause encephalopathy and cerebral edema. So we want to make sure that we know whether that's going up or down, and we're taking appropriate measures, which we will talk about in a little bit. In terms of extrahepatic, thinking about organ dysregulation that is associated with that dysregulated immune response, the inflammatory response. So you want to follow the renal function. Acute kidney injury is extremely common with acute liver failure, and earlier intervention has better outcomes. I didn't know that 1 in 20 patients develop pancreatitis with acute liver failure. It's quite interesting. So occasionally you want to be just making sure that you're checking an amylase or a lipase. I don't think we really do lipase routinely here, but an amylase. In terms of treatment, so I tried to sort of keep this in the format in which we would see it. So they've come up our A to I assessment. By the time they're coming to ICU, they're already pretty unwell, and they're probably pretty encephalopathic. At the point that they are at grade 3, then they should be really sedated and intubated to protect their airway. But you can consider doing it earlier if there is if the picture looks like they're heading that way, you're better off doing that sooner. We were talking about the risk of cerebral edema. So your choice of how you're going to ventilate and how you're going to manage the secretions and things, you want to try and reduce surges of intracranial pressure. You want to reduce that chance, so low tidal volume, 6 mils to 8 mils per kilogram. Targeting, rather than oxygen, you're mainly targeting CO2 between 4.5 to 5.5 kilopascals. Because of the risk of intracranial hypertension and cerebral edema, the recommendation is, for most people, is for a low expiratory pressure. If they have a hydrothorax associated with their liver injury, if they have ascites, it's not so much with acute liver failure, but you should drain that. And much like you would with any chest drain, you want to drain sort of 750 mils or so and then clamp it for 4 hours to avoid precipitating a refractory pulmonary edema, responsive pulmonary edema. Moving on to C, most people want to target a MAP of over 65. If there is evidence of raised intracranial pressure, then higher MAPs are required, so something like 85. We don't, at least here, I don't think we do routine measuring, invasive measuring of people's intracranial pressure, but at other intensive units, they may do or they might do, in which case a higher MAP target might be appropriate. Fluid resuscitation should be as if it is sepsis. The hypotension caused by that dysregulated inflammatory response is very much like sepsis. So it should be resuscitated predominantly with crystalloids in the first line. Noradrenaline is the recommended first line vasopressor, and vasopressin should be the first adjunct, ideally. Human albumin has a place in volume and expansion. There is a sort of measurable improvement in hemodynamic state, but from the sort of most recent review of the evidence, I don't think there's actually any change to the mortality based on that use. So your fluid resuscitation should be predominantly crystalloid and some HAS. Ideally, these people should have some kind of cardiac output monitoring, and shock steroids. I think if you're moving on to even things like vasopressin, they should also be on shock steroids. In terms of D, some of these people will be diabetic. Even if they're not, glycemic control is very challenging in these patients. So they should be started on an appropriate rate or variable rate or fixed rate insulin infusion. If they've got normal ketones, it will be a variable rate, aiming your BMs of 6 to 10. You want to be keeping a continuous check. If they are not fully sedated, then you want to be checking to see the progression of their encephalopathy at this stage, and in our daily reviews we should be doing that. In terms of access, they will need arterial lines, CVCs, and likely VASCAFs, because there's a good chance that they are going to need renal replacement therapy while they're on intensive care. In terms of those fluids, early consideration of the renal replacement therapy. In general, these people don't have citrate filters because their liver's not working so well. I think I was speaking to, I can't remember who it was, but I think they were saying that the evidence is that because the citrate's largely within the filter system, actually there's, perhaps this advice will change, but this is, at least for the time being, the advice that one should avoid citrate. In terms of gastrointestinal, we know with our chronic liver failure patients, we give them lactulose. We want them to be opening their bowels twice a day. We can give them antibiotics to try and clear their gut of some of its microbial element to prevent so much nitrate load to the blood. That's not. There's no evidence that that actually works in acute liver failure. So you would not routinely do that if there was, let's say, a young, otherwise healthy person who came with a paracetamol poisoning. There would be no reason really to be starting them on lactulose. And actually, if they're a candidate for transplant, the fact that you're filling their bowel full of gas with lactulose is actually a problem and can cause an issue when they're transported. So you wouldn't do that in this case. In terms of our bloods, HB of more than 7 is conservative. There is no evidence that targeting higher HBs is useful in this patient group. In fact, it can be harmful. We've already talked a little bit about replacement of clotting. Do not routinely replace clotting unless advised by a specialist team, or there is a specific reason why it needs to be done, for example, in some kind of procedure, or there's obvious bleeding. And rather than using our routine midnight bloods, you're better off using sort of up-to-date thromboelastography to guide exactly what products you should be giving, whether that's platelets or cryoprecipitate or fresh frozen plasma or whatever it might be. In terms of eye, a lot of these patients are very vulnerable to infection, and that's because of the immune paresis secondary to that dysregulated immune response that I talked about a few slides ago. So consideration of prophylactic antibiotics, and there's some recommendations that some of these patients should just be started on antibiotics. If they're for a transplant, then they almost certainly should be on some kind of prophylactic antibiotic in the days or hours before they have that transplant. And there is some slightly dodgy evidence, but some evidence that if there's evidence of intracranial hypertension, then one can have some targeted hypothermia. It's under review because I think there's a recent review of hypothermia in trauma patients that shows that it doesn't improve outcomes. So it's a slightly rockier ground, but there is some evidence that it's helpful in this case. So that's our acute liver injury, ICU A-to-I sort of treatment and what we're looking for. In terms of transplant, if the liver function does not improve with supportive management, then the definitive treatment is a transplant. I think the longest running criteria for identifying patients for transplant is the King's College criteria. There are other criteria, but having a look at the specificities and sensitivities of those, they're all actually pretty similar to the King's College. And I think we probably use that in this country. So I've put it up here for the time being. There is a differentiation between paracetamol and non-paracetamol. It's based on time and how quickly the liver function is falling off. A couple of contraindications: if they've got uncontrolled overwhelming sepsis, or if they've had some kind of really severe cerebral edema, high intracranial pressures that looks like that there is irreversible brain damage, then they wouldn't consider these patients for transplant. But early discussion with specialist teams and transplant teams is advised. If they're coming up to ITU, they should probably be discussed, or they absolutely should be discussed for an acute liver injury with specialist liver services. I think probably our closest is the Royal Free. That might not be right, but I think it might be. If they get the transplant, though, a 5-year survival of 82% in the UK. It's really pretty good. Like liver failure. So things that separate this from our acute liver failure. To wake you up, I was going to try and do a bit of interaction here. What sort of things, what signs and symptoms are suggestive of chronic liver failure rather than acute liver failure? And I'm going to eat some donut while people say it.
Are you talking about chronic liver failure or acute on chronic?
Both, to be honest, in this slide. There's signs of chronic and then an acute on chronic decompensation. Yeah. Yeah, if I choose, yeah. Anyone else apart from Tom? No, that's fine. Okay. So other things I was thinking of is hands and nail signs that we see: palmar erythema, clubbing, Dupuytren's contracture, that sort of thing. Issues with the collateral circulation caused by portal hypertension, so caput-Medici, prominent thoracic veins, that sort of thing. Estrogen signs of telangiectasia, palmar erythema, and sarcopenia. So SPB, I'm going to put down my donut. For a taste. So SPB. One of the commonest causes of a decompensation of someone's chronic liver failure. And this is generally caused by hematogenous translocation of gut bacteria. And because these patients don't have particularly good immune systems, they don't necessarily mount particularly good responses, which really are the specific signs for infections. Their fevers, feeling generally rotten. That's caused by the inflammatory response. So they may have few or no symptoms. They may be completely asymptomatic with this bacterial peritonitis. So if you have any suspicion, you start broad spectrum antibiotics. You don't wait for any results. You don't wait for cultures. You just start them on it. Particularly if they've had a previous episode, then absolutely you should. And sometimes they will be on prophylactic antibiotics anyway. Send acidic tap fluids. Often this will be done probably by the acute take team, maybe even in ED, a quick acidic tap. And we're looking for neutrophils of more than 250 cells per millimeter cubed. Obviously, if they grow something in it, then that would be an indication. All of these patients should have human albumin in addition to antibiotics. Serena syndrome. So this is something I didn't really know a huge amount about, beyond sort of finals exams, very basic. And I'll keep this quick and basic because I'm aware that I've been chatting for a while now. So broadly divided into two types, which I think is beginning to fall out of use. So I put the other terms that I think will become more prominent, it looks like are becoming more prominent, which is an AKI or a non-AKI associated hepatorenal syndrome. So type 1, the more severe form, and is perhaps more correctly called a hepatorenal syndrome AKI. It's a rapidly progressive AKI where you have that doubling of serum creatinine within 2 weeks. It basically appears on your renal profile the same as an AKI. What's key with the hepatorenal syndrome, particularly in the case of a type 1, is that this is a diagnosis of exclusion. So you should be first treating it as if it is a pre-renal AKI with appropriate fluid resuscitation. You should be doing a renal screen. You should be doing a urine dip to look for protein in blood to make sure there's no evidence of glomerulonephritides. You should be doing an ultrasound KEB to make sure that there's no evidence of obstruction. If that's the case, then you can diagnose a type 1 hepatorenal syndrome or a hepatorenal syndrome AKI. But you would treat it initially in a similar way as you would a pre-renal AKI with fluid resuscitation and trying to remove unnecessary nephrotoxic agents. So if they're on an aminoglycoside, maybe you can think about changing that. If they're on diuretics, perhaps you can think about stopping or changing those diuretics. In general, the outcome for patients that have a type 1 hepatorenal syndrome is very poor. It has a very poor prognosis. Type 2, which is perhaps more properly known as a non-AKI form, is a more steady, slow progressive decline over the series of months, and is normally associated with chronic liver patients with ascites. Initially, the first few years they're treating it well with diuretics, and they've now become resistant or refractory. For these patients, ultimately they will actually need a transplant to fix this problem. But we can give them things like terlipressin, or they can have a shunt TIPS as a bridging means. But for hepatorenal syndrome, definitive treatment is a transplant. Type 1, we treat that as if it's a pre-renal AKI and hope they get better and become a bit more stable. Key thing, diagnosis of exclusion. It's much, much more likely to be just a pre-renal AKI than type 1 hepatorenal syndrome. And I think, does anyone have any questions? I hope not, because I probably won't be able to answer.
I think there was a comment about the citrate in
I think
acute
we
liver
were
failure.
chatting about it at 9 p.m.
Yeah, because I was speaking to Dr. Skur about it, and he was basically saying there's increasingly better and better evidence that using citrate filters for patients with acute or chronic liver failure is completely safe, and you have less clotting on the filters as well. But obviously, it's not it's going against convention, and as with evidence-based medicine, things sort of come through slowly. Although there may be good evidence to show that it's safe. Just check with your seniors, I guess, to see what they're happy to run the filter on. Because I mean, if we've got a bleeding liver patient, we don't think twice about throwing packs and packs of red cells at them, which all have citrate in them, to stop the blood from clotting in the bag. And we never replace the calcium in that, and we don't really think twice about it. So I think that was the initial argument about why would we be afraid of using citrate on liver failure.
Interesting, thank you.
Yeah.
Well, if there are no other questions, I'll stop sharing my screen, and the next person can start. How do I do that? God, I'm such a boomer when it comes to this sort of thing. Okay, stop sharing. Okay, I think hopefully. Oh, sorry, there are questions here. What if there are no questions? Let's start. What? I don't know. Oh, it's writing what I say. Oh man.
Try now. So great. Over to you, Georgina.
Hi, are you ready?
Yeah, we can hear you.
Okay, great. My name is Nina. I'm one of the ITU SHOs at Ealing. I don't think I've met any of you, so nice to meet you all. I've been asked to present on sedation and delirium within ITU. So hopefully you can see my slides moving. I was asked to look at these particular areas. So looking at the prevalence cause of delirium, and then looking at non-pharmacological and pharmacological anti-delirium strategies, and then also to look into RAS scoring. So I just started by defining delirium. I think we all sort of know roughly what delirium is, but this is one of the formal definitions from the National Institute of Health. Another definition from the Diagnostic and Statistical Manual of Mental Disorders, 4th edition, also looks at these 4 domains. So disturbance of consciousness, changes of cognition, development over a short period of time, and fluctuation. These are the key areas that help us to sort of diagnose someone with delirium. Okay, and then there are 2 key forms of delirium. The most common in ITU being hypoactive, and this is characterized by these areas, so inattention, disordered thinking, and reduced consciousness. And hypoactive delirium is associated with worse mortality. And then the other form is hyperactive delirium. This is much less common, only less than 2% of people on ITU have this, and it is mainly associated with agitation. All right, so looking into the prevalence of delirium, it's actually quite poorly reported, I think because it's difficult maybe to quantify the number of patients with delirium, but these NICE reports report this data. So they think medical wards 20 to 30%, and long-term care, so that sort of nursing homes, would be more like 20%. And specifically looking in ITU, one study found somewhere between 20 and 80%. So that's not a very helpful number, but yeah, we're not entirely sure how much. And these are looking at episodes of delirium which sort of last between days to weeks. So the diagnosis of delirium is associated with an increase in mortality. So it is quite important to help identify and then to quantify how many patients have delirium. One study found that there was an estimated 10% increase in the relative risk of death for each day of delirium. And having delirium on ITU is also associated with reduced cognition long term. So these are some of the factors which can contribute to delirium. Delirium is a multifactorial syndrome, but it can be many things, but these are some of the things that commonly cause delirium. There's not really any particular investigations that can be done for delirium. It's generally a clinical diagnosis. Okay. And I was asked to look into RAS scoring. So this is a scoring system which helps to assess a patient's level of sedation and agitation. So it ranges from -5 to +14. I have the scoring system here. So 0 represents someone who's calm with normal alertness levels, whereas a more negative score indicates deeper sedation, and more positive scores indicate increasing agitation. So the idea behind this scoring system is that it allows closer monitoring of sedation levels, and then generally, I think we sort of hear it on the ward rounds, people aim for -2 to 0, as lighter sedation levels have been found to be associated with better outcomes for patients. Okay, so how do we diagnose delirium in ITU? There are 2 main scoring systems that we use to diagnose critically unwell patients. These are the 2 scoring systems. There's the CAM ICU. This is done at a particular time, a point in time. And then there's the ICD-SC, which assesses a patient over a slightly longer period of time. But these are the 2 that are available to us. There have been some trials which are looking into identifying sort of risk factors for patients developing delirium, and how to then rectify these risk areas. So these are some of the non-pharmacological anti-delirium strategies, what they're looking into. So these are the risk areas: orientation, sensory impairment, sleep, mobilization, hydration, nutrition, drug use. as I think we can all imagine, they're very important to make sure that patients get adequate sort of levels of these issues. So there was one trial in Madrid that was looking at 542 patients, all over 70, within medical wards and a geriatric ward, so not within ITU in this case. They looked at these 7 risk areas, and they implemented some educational changes and specific actions to help counteract these risk areas, so making sure patients are well hydrated, mobilizing frequently, all those sorts of things. And then they assessed the daily incidence of delirium, and they found that there was a reduction in incidence of delirium with a multi-component non-pharmacological intervention. So by targeting all these areas, they were able to help prevent cases of delirium. So these are some of the things that they were doing to help prevent delirium. So reorientating patients, reducing noise, making sure that people can hear and see as they should do, giving them hearing aids, etc., and many other things. So now looking within ITU and what can be done, I guess these risk areas can still be targeted, but specifically looking at ITU, have been some trials looking at daily sedation holds, which combine basically physiotherapy and occupational therapy at the same time as a sedation hold, compared with sort of standard care. And they found this whole body rehabilitation approach, i.e. sedation holds, physio, occupational therapy in the early stages of illness, resulted in better functional outcomes, shorter time on mechanical ventilation, and shorter delirium episodes. So the key really is just to get patients moving as soon as possible, get the physio input, occupational input when patients are off sedation, and that leads to better outcomes for patients and less likely to get delirium. Okay, so now we can look at some of the pharmacological anti-delirium strategies. So I thought it'd be helpful just to go over the triad of anesthesia first, just to think about what kind of drugs are used in ITU. So the triad of anesthesia is basically analgesia, hypnosis, and muscle relaxation, the 3 components which make up anesthesia. They can be used in different quantities depending on what the needs of the patient are, but the idea being that if all administered together, then this allows lower doses of each drug to be used. For analgesia, common medications we'll have seen on the wards are fentanyl and remifentanil. Muscle relaxants would be like rocuronium, and hypnotics, propofol, Dextor, benzodiazepines. I think the choice of sedative is often individual, based on sort of preference by the clinician, but often the short-acting agents are preferred, like propofol and remifentanil. Remi has a half-life of 3 to 4 minutes and has been found to be associated with shorter mechanical ventilation use and a shorter ITU stay. So there's some evidence that this shorter half-life may be associated with better outcomes for patients. Propofol has also been associated with shorter ITU stays. So there's that preference for shorter acting sedatives. So that's some of the stuff we use on the wards. So specifically, as usual, you can sort of split it into prevention and treatment. So in preventing delirium, we can use sedatives like Dextor, benzodiazepines. Some of these have been assessed in trials. So Dextor has been shown to be better at reducing the incidence of delirium in ITU, and also reducing ventilation length, and that was in a multi-center randomly controlled trial. So some evidence for Dextor. However, there are other trials which have shown no real significant difference between Dextor, midazolam, or propofol. So slightly mixed results. One for Dextor and one against Dextor. So we don't have very clear evidence on that yet. And also commonly used drugs are antipsychotics like haloperidol, risperidone. I don't think there's much evidence for those, but they are commonly used. But overall, the key message from The sedation hold trials that have happened in the past show that having a lighter sedation in patients leads to better outcomes, which is where the RASS scoring comes in again. So lighter sedation, lower mortality, and shorter duration of mechanical ventilation. And then looking at treatment, again, there are very few studies, very little evidence of pharmacological treatment of delirium. But there are a few small trials looking at quetiapine. There was one that had about 36 patients in, which was quetiapine versus placebo, and that showed a small benefit. These patients had shorter duration of delirium, and they were more likely to be discharged home at the end of their admission. But I think there's probably not enough data on that yet. But that's something I think we will see quite frequently, patients being started on quetiapine. So I think, yeah, in conclusion, I think the things that I took away from looking at these studies and looking at this paper was that lighter sedation is associated with better outcomes, less mortality. It's really important to look at the prevention of delirium, what we can do, especially in non-pharmacological ways, how we can help the patient to reorientate themselves, and getting the input of the physiotherapist and the occupational therapist to help mobilize the patient early, and that can help prevent delirium as well. So I think that is it. If anyone has any questions? Any questions?
Sorry, Georgina, can you show me your last slide, please?
This one?
Yeah, before that.
Or that?
Yeah, I have read the pharmacological strategy.
Mm.
Both of you, very good points, very practical points have been covered up. Maybe you can even relate all these things or phenomenon, both described by Jem as well as by Georgina in ICU, and you might relate this to whatever happening and whatever we had the treatment that we give. And maybe I can add some things about over here. Even it is said that we should assess whether the patient has delirium or no, and as far as possible, it is ICNAR which states that at least once during the shift of the nurse, that uh, assessment for delirium has to be done. And there are many scoring systems. Why we use CAM ICU is because it's very easy to perform, and in CAM ICU you come to know whether the patient is delirious, yes or no. That's it. Okay, based on that we will be treating the patient. Similarly, after the scoring, they have stressed on multiple therapies to be given at one point, and preferably non-pharmacological therapy, except for restrainment, because restrainment can result in some kind of physical or physical injury to the patient or no. And as far as drugs are concerned, yeah, you have rightly said that very few studies support uh, use of medicines. As far as use of haloperidol or risperidone is concerned, the most important point that has been specified by ICNAR is that uh, it only helps in breaking the cycle for a moment, but it does not give any added benefit. Instead, these two drugs can cause prolongation of stay in ICU. However, there are some promising results with dexmedetomidine. Uh, of late, benzodiazepines are going out of the question because they are known they are now becoming notorious to be worsening delirium rather than treating it. And yeah, quetiapine is the first line of drug that has been recommended by ICNARC so far. Coming to Gem, I was busy for some time. Uh, uh, yeah, yeah, as far as liver failure is concerned, first thing is use of child pube scoring does help in prognosticating the patient and at the same time knowing where you stand, whether to give treatment or not. You have rightly pointed out about coagulopathy. So yeah, we don't have to treat coagulopathy so aggressively, okay, because the patient is practically diluted rather than having some kind of ongoing problem. But definitely, if the patient is undergoing some intervention, or is if the patient is going to have some ongoing bleeding, you have to treat it. Otherwise, these patients can even bleed to death. Uh, and as far as one of the common factors that goes for renal as well as liver protection is always maintain a good mean arterial pressure so that the tissue perfusion improves, and that also might help in supporting the organ function. Any other questions from others, both for Jem as well as for Georgina? So I hope we have finished our presentation, and tomorrow I will be not tomorrow, by tonight I'll try to send Jem's feedback form. Meanwhile, please do fill the feedback form for Georgina, Ajay and Gusong. Okay. Thank you everyone and have a good day.
John Anthony. Yeah. Anthony Jones, yeah. Jones, Anthony Jones.